Hello, everybody. Thank you so much for stopping by and checking out my presentation on atrial fibrillation. Today is Monday, February the 21st of the year 2022. So let's go ahead and get started. So we're going to start with the patient case. Mr. Sanchez, a 62-year-old retired construction worker, presents to the clinic for his annual well adult check. He states concerns over episodic fatigue, shortness of breath, dizziness, and a racing feeling in his chest that have been ongoing for a week. Onset of symptoms occur when walking up a flight of stairs or when playing with his granddaughters in his yard. Vitals upon examination are as follows. He is currently 68 inches tall, weighs 235 pounds, has a heart rate of about 145 beats per minute, blood pressure is at 132 over 84, and oxygen saturation is at 92% at room air. Mr. Sanchez states that these symptoms began abruptly this morning after having his morning coffee and walking his granddaughters to school. They have become worse ever since. Current diagnoses for Mr. Sanchez include hypertension, coronary artery disease, sleep apnea, and diabetes mellitus type 2. Family history of Mr. Sanchez include myocardial infarction of first degree, mother and father. Brother currently diagnosed with diabetes type 2, and his sister has a history of coronary bypass surgery. Mr. Sanchez is currently taking lisinopril, metformin, fast and slow-acting insulin, as well as metoprolol. So this is the etiology part of the presentation, and what atrial fibrillation is it's caused by the irregular heart rate, which is an arrhythmia, due to uncoordinated atrial contraction. And here is a little diagram sort of displaying what atrial fibrillation is. We're going to dive a little bit deeper into that as the presentation ensues. But basically on the left we have a normal sinus rhythm, which is when the spinoatrial node, which is the pacemaker of the heart, um, sends electrical signals um, evenly, to the four chambers of the heart. On the right we have an atrial fibrillation diagram where there are chaotic impulses, and we're going to dive a little bit deeper into this. So just some facts about atrial fibrillation. Uh, Atrial fibrillation is the most commonly treated cardiac arrhythmia. AFib has been found to have a direct link with ischemic stroke, and they actually cause about 1 in 7 strokes. AFib was classified as an underlying cause of death in 26,000 out of the 183 death certificates in the United States in 2019. And since on average women live longer than men, more women will be diagnosed with AFib. Now, this doesn't mean that women are at a higher risk of, being diagnosed with atrial fibrillation, but just the sheer fact that they live a little longer means that the probability definitely increases. And here are just some risk factors associated with AFib. Older age, so risk increases with age. There is a family history as well as a genetic component to AFib. Cardiovascular diseases that cause inflammation and stress to atria. So we're going to go over some of those in later slides. Uncontrolled hypertension. Non-cardiovascular diseases like hyperthyroidism and diabetes also increase the risk. Night shift work, inactivity, alcohol and caffeine consumption, and obesity are considered some of the major risk factors for AFib. And if we actually tie this back to the case study regarding Mr. Sanchez, we see that he encompasses a lot of the risk factors associated with AFib, including being of an older age at 62 years, mother and father both succumbing to myocardial infarction, so there's definitely a family history component in there, being diagnosed with hypertension and coronary artery disease, daily ingestion of caffeine, which is a stimulant and does have an effect on the heart, as well as having a BMI of 35.7, which is considered to be obese. Taking into consideration his height as well as his weight. So let's start with the pathophysiology. So any condition that leads to chronic stress, inflammation, and physical damage to the heart place someone at an increased risk of developing AFib. So some of these cardiac diseases include hypertension, atrial ischemia, structural heart disease, coronary heart disease, heart failure, pericarditis, myocarditis, and atherosclerosis. So this added cardiac stress changed the structural integrity of the atria, which leads to cell damage and fibrosis. This is known as cardiac remodeling, and we're actually going to go into it a little bit more in the following slide. So fibrillation occurs when muscle fibers contract at different times. That's what atrial fibrillation is. And it causes this quivering in the atria of the heart. So cardiac remodeling of the atria results in the onset of AFib, and this is important because cells in atria undergo functional and structural changes that result in tissue heterogeneity, which basically is when adjacent cells differentiate in task. This is due to chronic cardiac inflammation and stress. So basically, when there's chronic inflammation or stress on any cardiac structure, there is going to be cell differentiation, which means that cells are going to act differently than their adjacent cells. And we don't want this because this could actually change the way that cells receive and actually send out electrical signals. Remodeling of the atria can result in electrical malfunctions which may cause changes in the rhythm of the heart in one of two ways. So there is the multiple wavelet theory, which states that affected cells in the atria cause the release of multiple sporadic wavelets which can produce daughter wavelets upon collision with one another. Just think of atoms sort of floating and being in a high energy state and colliding with one another and being sporadic. That's what it basically is. And we also have automatic focus theory. That states that there is a specific origin that causes the rapid firing of electrical impulses, which override the function of the sinus node. So here we have a comparison between a normal heart contraction and an AFib contraction. In a normal heart contraction, we see that an electrical signal is sent from the sinus node in the right atrium, which then travels quickly to both atria. This causes simultaneous depolarization of the atria, which result in a coordinated contraction of both atria. The signal then travels to the ventricles and causes them to contract, resulting in contraction of the ventricles. And we're actually going to see this in a future diagram. It's actually animated so we can, have a clearer picture. And in an AFib contraction, electrical signals actually override the sinus node, which result in sporadic signal traveling, causing smaller dispersed contractions in both atria. And this definitely goes back to the two multiple wavelet theory um, that we discussed in the previous slide. So signals then travel down to the ventricles, which cause irregular contractions. And here we see the animation. On the left, we have a normal heartbeat, as we can see that there is a uniformity to the muscle contraction. We can see that the electrical signals flow in one direction, and on the right, we have an irregular heartbeat, and the signals are all over the place, causing the heart to beat too slowly, too quickly, or irregularly. So there are a few ways to classify atrial fibrillation. The first one is the paroxysmal AFib, which is the spontaneous onset and cessation of AFib, usually lasts less than a week. So AFib symptoms usually come and they go on their own. Persistent AFib, which means that AFib symptoms last more than a week and does not spontaneously cease, which means it doesn't go away on its own. And this is what is believed to cause that fibrosis in the atrium cells, which leads to cardiac remodeling. And then we have long-standing AFib, which, AFib usually lasts for more than 12 months. At this point, it is considered chronic. And both the patient and the physician both agree to have no intervention done to stop the arrhythmia. So here are some symptoms and complications. Um, so some of the major symptoms include palpitations, arrhythmia, chest pain, dizziness, lightheadedness, general fatigue and weakness, and shortness of breath. And there is a large percentage of people diagnosed with AFib that have had no prior or recurring symptoms. So people can be walking around, with this serious diagnosis and not even really know. And the reason why it's serious is because one of the major complications of AFib is ischemic stroke due to blood clot formation in the heart. And as we know, this is what we call an embolism, where the blood clot is formed elsewhere in the body and it travels to the brain, causing that cutoff of oxygen to the brain. It could also lead to heart failure, chronic fatigue. I know it's not in here, but I know that it could actually exacerbate any existing cardiac issues that one may already have. And going back to the case study, we see that Mr. Sanchez displayed some of the more classic signs of AFib, which include palpitations, which he described as a racing feeling in his chest, abnormal dizziness, lightheadedness, and shortness of breath when walking up a flight of stairs or playing with his granddaughters. This ultimately signaled that reduced in physical capability because the heart is unable to pump blood, oxygenated blood, as effectively. So how do we diagnose AFib? Well, one of the major ways is through an electrocardiogram, and physicians specifically look for an absent P wave. If there's an absent P wave, there is a pretty good chance that the patient might actually have atrial fibrillation, as well as having an irregular interval between R waves. And we're going to go ahead and look at this in the next slide. Physical examination from a physician who notices abnormal heart dysrhythmias and palpitations through a stethoscope can also be used to detect AFib. Okay, and so here we have a comparison between a normal EKG and an AFib EKG. So this isn't labeled, so I'm going to go ahead and do that right now. So this is what we call the P wave in an EKG. Usually, if a patient has AFib, this is going to be absent. The P wave right before the Q wave, which is down here. So in a normal EKG, we could clearly see the P wave. We see that descent into the Q wave, then all the way up to the R wave. And then from then it just keeps on going. And there is a uniformity to this. So in a normal heart, this entire section, which takes up 5 large squares, will actually be dispersed evenly. And this is what we call that interval. My writing. It's not the best, but you can make it out. So this is what we call an interval between the R wave, between, the first R wave and then the second R wave. So this is a normal EKG. Now, if we look at an AFib EKG, we could see that this interval is all over the place. There. So we could see that this one is a little bit shorter than this one, and then this one is a little bit shorter than the third one, and then these seem to be about the same length. But we can see here that, that there is that lack of coordination, that basically the S and the T phases, they're sort of all over the place. So that's how we can, distinguish. And there's also that lack of an obvious P wave in a lot of these. So how do we treat it? So medications to control heart rhythm and rate, as well as anticoagulants to prevent blood clots from forming, are used to treat AFib. This ultimately reduces the risk of stroke. Medication selection is determined through what we call a CHA2DS2/VAC score, which considers age, sex, cardiac history, hypertensive history, as well as other non-cardiovascular issues that affect one's risk. So depending on the score, physicians recommend certain medications, certain treatments. The implementation of a healthy lifestyle, cardiac procedures that shock or scar tissue in the heart to obtain normal heart rhythm, creating electrical pathways or blocking them altogether. So an example of this would be radiofrequency catheter ablation, a MACE procedure, or an AV node ablation. Uh, Also, installing a pacemaker can really help. And that was my presentation for atrial fibrillation. I hope you guys enjoyed.